crisis. And I've been a trainer for Addiction Technology Transfer Center for many years. And so I've made my way to Iowa a few times to present on medication-assisted treatment. Today, the focus is going to be on medication-assisted treatment for adolescents with opioid use disorder. We have a lot of great evidence that medications for opioid use disorder reduce mortality, reduce illicit substance use, and all of the associated harms in adults. We have very limited evidence on adolescents, and so that raises the question, what should we be doing with adolescents? So what I'm going to do is just give an overview of what we do know and what we might infer from what we know about adults and the relationship between adults and adolescents in terms of treating adolescents with opioid use disorder. A couple housekeeping items. I'm recording this webinar, and the slides will be posted at the link here. There will be a survey following the webinar and also a 30-day follow-up, and this is approved for 1 hour of substance abuse counseling continuing education units. For the purposes of this presentation, an adolescent is, we're really looking at the ages 10 to 24 category. Some of the studies are 15 to 24, but generally that's the research angle where we have information. Obviously, there's a bit of a difference between a 17-year-old and a 24-year-old for sure, or a 12-year-old and a 24-year-old, but this is a time of immense physical, cognitive, emotional, and social change, and it's also the time in which people start using substances in larger numbers. The adolescent brain, I'm sure there are people on this call who have parented adolescents, and it is something to behold. I always say that there are two most exploratory periods of human development are when you're a toddler or a teenager. In both of these periods of development, there are major changes that force the human organism into the environment to explore and to try and to seek sensations. With toddlers, the big change that happens is that they're able to move themselves. So when they start to crawl and walk, they're exploring their environment in great detail and trying everything. And there's a lot of risk involved in that because they have not yet developed the risk aversion or the self-control or the discernment to know what's harmful or not. Adolescents are the same way. During the period of adolescent development, the hormonal changes impact their drive to explore and to try and to sensation seek. And yet the prefrontal cortex, which controls impulses and helps with reasoning and planning and goal setting and engages in consequential thinking, does not develop fully until the late 20s. And so, like the toddler, there's a real need for parenting to prevent risk to adolescents. And so like the toddler who will cry and say, but I want to try this, or I want to put that in my mouth, or I want to put that fork in the socket, and we just have to say, hey, you can't do that, and just tolerate the tantrum. Teenagers also can be very emotional about their goal-directed behavior, and it's so important for the parents to be a surrogate prefrontal cortex and really set limits and be able to tolerate a certain degree of emotionality from teens around things that are harmful to them. Here's what it looks like. Past year, since we're focusing on opioids, I put this chart up. This is National Survey on Drug Use and Health, 2017, our most recent data. And you can see that during early adolescence, opioid misuse by age group starts going up, and then it spikes in the ages 21 to 25. But it makes some pretty big gains in that 16 to 17 and 18 to 20-year-old range. Now, if we're looking at marijuana or alcohol, the onset of use would be even a little earlier because there's a bit of a lag for opioid misuse compared to those other two substances. So adolescence is really where things get started. In thinking about how to treat all substance use disorders, but again, we're focusing mainly on opioid use disorder in particular in this presentation, we can think of 3 levels of intervention. There's prevention, which is universal population-based prevention. And that's not just going into schools and teaching kids about health and teaching kids about drugs. In fact, there's very, very little, if any, evidence to support universal prevention as an educational drug program in schools. In fact, there's some indication that sensitizes the kids that are sensation seeking. They learn more about the drugs that they want to use, and the ones that were risk averse were already risk averse, and so it may not be the best intervention at that level. Structural barriers such as laws that, the drinking age being 21 versus 18 definitely had an impact in lowering alcohol-related deaths in this age. Taxation making things more expensive, policies against adolescent use, all of those do show some effectiveness. And the family can be a place where you create structures that prevent the onset of use or the onset of regular use. I'll talk a little bit more about that. Early intervention and harm reduction. This is when we start to get, we use targeted prevention, where we find those kids who are more susceptible to using, and we target interventions towards those kids. I'll talk a little bit about that. And we screen. There's been a lot of debate over the last years. How much should we be screening adolescents for opioid use? I take at least as one thought experiment, I asked the question, well, if we had an infectious disease that was killing so many people, and I'll show you the mortality statistics very soon here, but becoming a leading cause of death among this age group, and it was really an infectious disease in the sense that it spreads peer-to-peer, which is what opioid use disorder does. And it was sort of a hidden thing. We couldn't know oftentimes which kids were affected by it and which were not. If it was any kind of health or medical infection, we would test every kid in school, or we as families, we'd go and test them to make sure that our kid were safe, or that our school population was safe, or we'd identify those kids that had been effective so we could intervene. But there's a lot of reservation to drug screen. And I think the more drug screening we did at the school level or the family level, the more we're going to get be able to treat the problem earlier and prevent it spreading to other children. That's something at least to think about. And then, of course, treatment. And when we talk about medication-assisted treatment, we'll be focusing on how that interacts with psychosocial interventions as well. So yes, even though the kids may not like it, parents are the first line of defense in preventing risk behaviors in kids if they're inclined to try them or to take them to a level that's too dangerous. And if you want a little bit of indication of this is from Monitoring the Future study. And there's a lot of indications in Monitoring the Future study, or like parent behaviors, and this is just one. And so when parents limits the time with friends in the past year by substance use disorder. So this chart basically shows that when parents, if a kid says, yeah, my parents always limit my time with friends, they put this limit on me, they don't just let me kind of, run wild with my peers, there's a huge difference in the number of kids who have a substance use disorder or report a high level of supervision versus don't have a substance use disorder. And what that shows is just how important supervision is. Now, if you look at the next three categories, there's not that much difference between the groups. So if a child has, or an adolescent has, the perception, their parents pretty much are setting limits and determining what environments they're going to be in. There was another question very much like this in a prior version that said, my parents always know where I am after school, or sometimes or seldom and never. And the chart looked exactly the same. It was only in the always category where parents are really on top of what their adolescent is doing. That doesn't mean that they're necessarily invasive all the time, but there's a high level of supervision that prevents the exposure through peers to substance use and prevents a substance use disorder from developing. Now, this is correlational, not causal. It could be that the kids who are more inclined to use substances are also finding more opportunities to use, but I think it's suggestive anyway of the role of supervision. Now, when I think about high schoolers or teenagers, I really, kids come into the clinic, and when they come in, one of the things they want to tell us is that every kid drinks the way that I do, right? All the kids are drinking all the time. So if the parents have brought a child in because they're getting drunk on the weekends, or they're perceived that they're developing an alcohol problem, or maybe they've just had one or two alcohol incidents that they're concerned about, the teenager will normalize that. So I always show them this chart and I say, well, how often do you think high school seniors, how often do you think they drink? Well, the truth is, from our best data, almost 70% of high school seniors have not had any alcohol in the past month. Another 19%, so about 1 out of 5, have drank 1 to 2 times in the past month. And only 14% are what I would consider weekly drinkers, right? They've drank 3 or more times. So these are the kids, that 14% of the kids that are going out with their friends pretty much every weekend and drinking at least once. Now, when I look at the severity of alcohol use in this group, obviously, if you haven't drank in the last month, you haven't binged in the past 2 weeks. But if you look at these two groups, the ones that have drank once or twice in the past month versus the ones that have really graduated towards weekly regular drinking, there's a big difference in the percentage who have binge drink. Binge drink is a good indication of very risky drinking. It comes with other risky associations and behaviors. And that category, that red category, is the one that clinically, I think, these are the kids who are the very highest risk for problems. But they're only about 14% of adolescents. So frequency of drinking also is a good indicator of the amount and severity of drinking. So parents can affect drinking. This intervention this was published in the Addiction Journal, and it was a school-based intervention that targeted both parents and students. With parents, the big, sorry, I don't know why my thing is sort of voluntarily jumping ahead, but I apologize for that. For parents, the intervention was to say, hey, what do you think about what your rules for drinking should be in this coming year? And it was done with freshmen. And parents would talk about what limits they want to set. And there was a subtle encouragement to get parents to agree to more deliberate and abstinence-oriented rules, not having a lot of room for drinking with their children. And so getting parents on board for that. With students, one of the main emphases, and the emphasis that was most associated with a good clinical outcome, was supporting student self-efficacy. They would go through these online modules that helped them realize that no matter what their peers were doing, they could choose whether or not they were going to drink on any one occasion. And students, what was found was that the intervention was successful in both of those, that parents who had more rules and the students that had this increase in self-efficacy, there was a decrease in the onset of weekly drinking, so becoming part of that red group that I showed you before. And so as terms of an intervention for prevention, parents and schools and these rules and student self-efficacy are really important. Now, the reason I start with alcohol is because alcohol does usually precede anything like opioid use. And we've got a lot more research on interventions that work there. So even though this isn't directly related to opioid use, it's important for all substance use disorders and for the progression from one substance to another. We know if we can delay the onset of use period, the onset of any real occasion of drinking, not just a sip, but having alcohol and getting the effects, that every year we delay it, there's a lower rate of lifetime alcohol abuse in adults. In terms of parent training even earlier, this is a study that I did with collaborators at Washington University Psychiatry Department. And we looked at the Incredible Years parenting intervention for kids who had some antisocial behavior that they were demonstrating. And some of them had a familial history of antisocial behavior and others didn't. And we found that the parent training showed an equivalent positive effect on child externalizing behavior, even at that young age. You'll understand as we kind of look a little bit further at the traits that predict substance use, why it's important to target externalizing behavior very young like this, with this particular slide. So there was another intervention that we talked about universal intervention not being all that research based. We don't really have good indications that it works very well. It's also really expensive to teach all kids in an entire population something, and if we don't think we're getting a gain from it, it's probably not the way to go. Targeted intervention instead says, okay, can we know which kids are at highest risk for substance use disorders? And in fact, this particular group of research that was published in JAMA a few years ago found that hopelessness, anxiety sensitivity, impulsivity, and sensation seeking, if we measure these traits in middle schoolers, it predicts about 90% of all later substance use disorders. Two of these traits are internalizing, hopelessness and anxiety sensitivity. Hopelessness is also the symptom of depression that is most highly correlated with suicide completion. So it's a kind of a deep sense of depression. Anxiety sensitivity is not anxiety. A lot of high anxiety kids kind of power through and they live with their anxiety and they cope with it okay. Anxiety sensitivity are the kids that when they feel anxiety, they get anxious about their anxiety. So they feel anxiety, they feel themselves sweating, they feel their heart racing, and they feel really anxious about those symptoms, and then there's a feedback loop. This is what is at the heart of panic disorder, where someone notices some physical symptoms of anxiety like sweating or heart racing, and they begin, as they notice them, to hyperventilate, and then the heart races faster and the sweating gets worse and they start to get numbing and tingling, and they think they're having a heart attack or having a mental health crisis or like a break with reality, and then present to the emergency room and they say, nope, you got a panic disorder. So even though it's not always manifest in full-blown panic disorder, a high level of anxiety sensitivity predicts a strong response to trying alcohol or trying marijuana, because obviously if you're living with that anxiety sensitivity or you're living with that hopelessness, when you have those drugs that for the first time make you feel okay or make those symptoms reduce, it can be very alluring. So those are the internalizing pathways. The externalizing pathways, which are actually predictive a bit earlier in development than the internalizing pathways, are impulsivity and sensation seeking. The kids that just follow any impulse they have without being able to think about it or having less time to think about it, and sensation seeking, which is just a high need for stimuli. Sensation seeking is seen in a lot of kids with ADHD, as is impulsivity, so these externalizing traits. If we measure these traits in middle schoolers, we capture a large majority of those kids that are at risk for substance use disorders. So in this particular intervention, what they did was they measured the whole class or the whole population of the school, and they identified kids with each of these 4 traits, and they sent all kids to groups for an intervention, and they tailored the intervention for each of the 4 traits. Now, kids didn't know whether they were measured for one trait or another. They didn't know anything about the traits. They just knew that they were assigned to a group, and they received an intervention that was targeted towards their trait or just general education. And what they found was that the control group, the control HR group, that's the group that didn't get the intervention for the trait that put them at risk, had a higher quantity of drinking over time 2, time 3, time 4, time 5, and that the ones that did get the intervention looked more like the low-risk groups, which is exactly what we would want. Similarly with binge drinking. And so if we target, this is a pretty recent study, and targeted interventions are a little bit more recent in their focus, but they show real promise in helping to prevent the onset and the progression of substance use disorders. Also, because ADHD is associated with those 2 characteristics of impulsivity and sensation seeking, it's important to get psychiatric treatment for kids who have real ADHD. I know that can be difficult because you're putting a kid onto a controlled substance, but there's good evidence that if we treat ADHD, that there's an almost 2-fold reduction in the risk for substance use disorder. compared to kids who did not receive pharmacotherapy. I think of a kid that came to me who had, you could just see it in him. He was a delightful child. His sensation seeking was unbelievable. He couldn't focus on me for half a second, but he was constantly talking and entertaining and like just going kind of a mile an hour. And when he was on his medication, I could tell within 30 seconds of him walking in the room whether he was taking his medication or not. Now he would say, well, I don't really like my medication. I feel like it takes away some of my personality. And it did. I mean, his unmedicated personality was pretty out there and fun, but not very productive in an environment. In a school environment, what it led to was that he'd go into class with this larger than life personality, and he would talk impulsively, and he would follow every impulse he had, and he would make jokes, and he would get in trouble. And over time, getting in trouble constantly also led to depression and a feeling like there's something wrong with him. When he treated his ADHD, he was more focused, and when he was outside of school, he wouldn't take medication, and he could be his more lively self. But it really helped him to be more productive and to stay on task and not to be disruptive in school. And it made him less impulsive, which is important for averting progression to substance use. So up until now, I've really talked about substance use disorders without really focusing on opioids, because they're all connected, right? But we also know that in the past 20 years, there's been real change, 20 or 30 years, that there have been more and more adolescents who are receiving controlled medications, including opioids, and even more so in young adults, that there's just been an increase in the prevalence of these prescriptions, and that has put kids at risk. The last Surgeon General, not the current one, but the last one, wrote a letter to every doctor in the country. And they said, look, we have this opioid crisis. This opioid crisis is largely iatrogenic, which means caused by doctors. And part of the reason that we as physicians played such a large role in the creation of this crisis was that we were taught incorrectly. In the first line of the letter, it says, many of us were taught incorrectly that treating legitimate pain cannot lead to addiction. My analogy for that is that's like saying that you can't develop an alcohol use disorder if you only drink while you're watching football. Like, there's just no connection between those two things. Opioids are powerful substances, whether you're treating legitimate pain or you're using them recreationally. And that idea that treating legitimate pain is not risky has been completely debunked. It was a myth that was put forward by the pharmaceutical companies to try to decrease the inhibition that physicians might have had to prescribe opioids. And we can see this now, that when adolescents are prescribed opioids, they have for legitimate pain, they have a 33% increased risk for future opioid misuse after high school. And what's even more troubling about this particular study is that this association is concentrated among individuals who have little or no history of drug use and a strong disapproval of illegal drug use at baseline. This was a well-designed study that looked at, was prospective. So it measured students at the beginning, then it looked at those that did receive medication for pain, and it could look back and see whether those kids were already having a history of drug use or not. And what they found was that that basically prescribing opioids to a kid who doesn't have any of the risk factors for drug addiction still increases their risk significantly for later opioid misuse. This is a little different than most of what we look at in studying substance use disorder, because it is so particular to opioids that this exposure through a physician to a drug, a type of exposure that could happen to any kid irrespective of their characteristics, can put a person at risk. And of course, anecdotally, you hear about the kids who are, star athletes, and they broke a bone, and then they got opioids, and then they were, there probably is some genetic susceptibility to maybe the response to opioids, but nevertheless, that led to a really tragic end. So that's something to look out for. It doesn't mean we shouldn't treat pain with opioids in certain scenarios, but we just have become much less liberal about it. And if you're a parent of a child who really has to have opioids for some procedure or something, monitoring that medication, holding on to it, using only as much as is necessary to manage the pain is really important. So let's consider the opioid crisis in adolescents and adults. You've probably seen the charts and graphs from the New York Times and from other periodicals that show this just unbelievable increase in deaths associated with opioid use in the adult population. Well, it's not that much different in the 15 to 24-year-old population. These are deaths per 100,000 in just that 15 to 24-year-old age group from 1999 to 2017, broken down by three kinds of opioids. Heroin, well, prescription opioids, which is the other opioids, should have said prescription opioids there. Heroin, which is the blue, and other synthetics. And now, naturally, you look at those other synthetics and you say, oh my gosh, from 2013, it's like took off like a rocket ship. And that is what people refer to as the fentanyl epidemic. Just around that time, in 2013, 2014, there was a massive diffusion of illegal fentanyl. Other synthetics are not pharmaceutical medications. They are synthetic, illegal opioids. And the reason that the producers of illegal drugs decided to start using fentanyl in place of heroin is because heroin has to be derived from a poppy. And so you have to grow fields and fields of, miles and miles of fields of poppies. You have to wait till they mature. You have to scrape the white sap. You have to cut open the bud, scrape out the white sap, and extract the morphine and turn the morphine into heroin. It's an expensive process. It takes a lot of time. Even though street heroin is really cheap, there's still a lot of production process involved. Fentanyl, you just need the chemical precursors, and you can make it in a lab in just a building. And you just need some scientists who know how to do it. And so large amounts of fentanyl are being manufactured in China and shipped. It's 50 times more powerful than heroin, and it's a fraction of the cost. And for that reason, it has become to dominate the heroin supply or the opioid supply in a lot of parts of the country, and it has affected this age group just like all other age groups. But if you think about the history of this chart, also shows you the history of the opioid epidemic. If you go back to 2000 and you follow that red line, that was when I would go and present, I would say, prescription opioids cause more overdose deaths than heroin and cocaine combined, because that was the biggest problem. Up through 2011, prescription opioids were the number one cause of death among drug overdoses. And then you see this sharp incline in heroin. That was our heroin epidemic. So we had a prescription opioid epidemic, then we were followed by a heroin epidemic, and now and that went on for about 5 years. And then you see this shooting up line, which is the synthetic, which is really the fentanyl epidemic. And so it's been 3 phases, and it's scary to think of the phase we're in now because there's been such a sharp increase, and it continues to increase. We're in epidemics, you hope for a plateau, and we may be seeing that, but as the rapid release statistics come out, it still looks like it's increasing. To think about it another way, or to just give you another visual, this is these are the top causes of death for ages 15 to 24 in 1999. Now, if you look down this list, it will tell you, just start reading kind of at random, it will tell you something about how people age 15 to 24 die. It's not generally from disease. It's generally from an accident because 15 to 24-year-olds are on the whole healthy compared to older adults. If they die and their rate of death is lower than older adults, they generally die of some kind of injury. If you look down this list, you'd have a hard time finding anything that was drug related. You can see them down here. There's other and unspecified drugs or biological substances. So that's 1, and so there's about 2 deaths per 100,000 there. And then respiratory failure, the only reason I highlighted it is because that is if you die from opioid overdose, you die from respiratory failure. So it may be that some of those respiratory failures are coded, but there's really some opioid use there. Jump ahead to 2017, and you have a same size list, top 24. That's what I could fit in the slide. And you have 3 mentions of opioids in the top 24, and one is number 5. That's the other synthetics. That's the fentanyl. Go down to heroin, 3.4. Go down to other opioids, 2.1. And then if you look a little more closely, there's all kinds of other mentions of substances. There's the other unspecified drugs that we saw in the other chart. Accidental poisoning, mental and behavioral disorders due to multiple drug use. So it's like if you're 15 to 24 and you're dying now, if you add up all these together, it's almost the number 1 cause of death. Now, there could be some overlap here, so I won't make that claim, but it's becoming really, really dangerous. It's really becoming a leading cause of death in this age group. And then in the other chart, there was no mention of any other substances, but here we also have 3 other substances: benzodiazepines, cocaine, and psychostimulants. And the important thing about this is that, benzodiazepines usually cause death in combination with opioids, not by themselves. Cocaine now is often laced with fentanyl. And so really the opioids probably are showing their fingerprints all over this chart. So what do we do about it? Adolescents and young adults are a special population. They're that same group that has not fully developed their prefrontal cortex. They don't have as much self-control. They're exploring. It's an exciting time, but not everything that works for older adults works for adolescents and young adults. The standard psychosocial treatments for substance use disorders, I'm sure many of you are familiar with. There's motivational interviewing, cognitive behavioral therapy, and contingency management. And then for adolescents in particular, multisystemic therapy. Motivational interviewing is a counseling style. It's meeting the person where they're at. It's not being confrontational. It's helping them to develop discrepancy between their current behaviors and what they want out of life. It's very effective with adolescents. We have one therapist in our office who just does a bang-up job engaging adolescents with motivational interviewing. Cognitive behavioral therapy is the more like analytic relapse prevention, helping individuals understand the relationship between situations, their beliefs, the patterns of thought that those beliefs generate in a relationship or in interaction with the situation, and then the behaviors that result, in helping them analytically massage those leverage points, change the way they think a bit, change their behaviors to create feedback to their cognitions and emotions, et cetera. It's a very analytic and proactive type of therapy. Contingency management has shown some effectiveness with adolescents in keeping them engaged, giving them control. If I know I can prevent a negative reinforcer through a desired behavior, I know I can get a reward. That can work pretty well with adolescents or with adults with substance use disorder. And then multisystemic therapy is really a type of therapy that looks at the adolescent within their ecosystem. And so it says this adolescent touches that coach, and they touches that teacher, and it touches that principal and their parents and friends. And the multisystemic therapist gets everybody involved in helping support behavioral change in an adolescent who's struggling. And that's shown some decent results. However, there's no evidence anywhere that these interventions reduce mortality risk in adults with OUD. And I say limited evidence. There's limited evidence about adolescents to begin with. There's no evidence that these interventions reduce risk for mortality in adolescents with OUD either. That's a sobering thing. I'm a social worker. I didn't say that at the beginning. I'm a licensed clinical social worker. And when I face an adult or an adolescent with an opioid use disorder, the first thing I have to do is recognize that this is a medical problem, that the way that opioids affect the brain and functioning, the degree to which the brain gets attached to future use of opioids is beyond the scope of talk therapy, is beyond the scope of behavioral management by itself. At least that is what the literature, the science that we have currently suggests. Now, this is an adult population, and I'm only using it for comparison, but this is the opioid use disorder population in Massachusetts. And this looks at treatment over 3 years, people that are receiving opioid use disorder treatment over these 36 months. And the y-axis here, the 0 to 50 on the left there, that is the number of relapse events in any given month of treatment in 3 different kinds of treatment. The red and the blue are people that receive buprenorphine or methadone. The green is behavioral treatment, psychosocial treatment only. So in that first month of treatment, there are almost 45 relapse events per every 100 months of behavioral health treatment, psychosocial treatment, and only 5 in the buprenorphine or methadone groups. So 9 times fewer. And then over the course of 36 months, the instability of patients in the behavioral health treatment is obvious. And the protectiveness of buprenorphine and methadone is also obvious. Now, if I'm preventing relapse events, I'm also preventing death. There's no question about that. If I'm using so much that I need to show up at the emergency room or be hospitalized or be detoxed, I'm putting myself at risk for death, especially given how potent, as we talked about, how lethal the drug supply is. So we don't have yet cohort studies of this magnitude for adolescents, so I will show you what we have. So if we ask the question, well, okay, that's the adults, Ned, but maybe the psychosocial interventions are more effective with adolescents, maybe just because they're younger. Now, the first thing I would say about that is that's a strong assumption. I think the assumption that psychosocial treatments would be more effective with adolescents is based on the idea that maybe their illness is not as severe because it hasn't had as long to develop. And there may be something to that. But again, we're talking about opioids. So if they become hooked on opioids, they've probably used other substances prior, unless they're in that small group of people who really developed opioid use disorder through pain management. So I'd question that assumption a little bit at the beginning. But the other thing we have to think about is that psychosocial interventions rely heavily on the prefrontal cortex. They're about consequential thinking and reasoning and insight. And adolescents aren't real good at any of those, risk aversion and weighing risks and harms. And so we're not using a resource in psychosocial interventions that come very easily to especially adolescents and certainly also young adults. So this particular review of all kinds of interventions, this comprehensive review that was published in The Lancet just a couple years ago, tries to look at every possible intervention. And I'm only going to cover the treatment because that's what we're most focused on. But it's a great review article if you really want to know what works with adolescents. In treating the substance use problems or dependence in young people ages 10 to 24, if you look at this chart, it's a little confusing, but it says, okay, what evidence do we have that this particular intervention reduces use? The interventions are there on the left. What reduces problematic use? So use is just the starting use, the initial use that kids use. Once use becomes problematic, it's in a certain severity, and then harms related to use. And if there's an X, it means we've studied it, but it's not effective. If there's a question mark, it means there's mixed evidence and inconclusive or mixed evidence. We really can't say anything about what we know from the studies. If there's a line, that means we just haven't even studied it yet. There's been insufficient evidence to even make a generalization from. If there's a check mark, that's the only category where we have some evidence of positive effectiveness. And now the question mark that comes after that actually is a little bit misleading, because that means there's definitely a small effect and there may be a moderate effect. If you look at the chart at the below, it goes from small effects, mostly small effects, but findings are mixed, meaning there might be even larger effects, and then moderate effects, more check marks you get. With adolescent treatment, and this is substance problems. These are illicit drugs. I teased out just the illicit drugs. There's other charts for alcohol and for nicotine. We have very, very little evidence. But the evidence we do have of effectiveness lands squarely on pharmacotherapy. The best clinical trials have been developed to show that this retains kids in treatment, young people in treatment, and prevents the harms associated with problematic use. And yet, even though we know that we have very little evidence for illicit drugs, that these standard psychosocial interventions work well with adolescents and young people, that's almost all that they get. So if you look at the number of people, this is a recent article that looks at how many young people with opioid use disorder in these different age categories over the years have received pharmacotherapy if they have opioid use disorder. And if you're, let's just look at that 18 to 20-year-old category, the blue category, in 2014, after there'd been an initial increase with the release of buprenorphine, only about 1 out of 5 18 to 20-year-olds with opioid use disorder received medication. That means that everybody else that's receiving treatment in this group, the other 4 out of 5, are only receiving psychosocial treatment, and yet there's a much better evidence base for the medications. Now, it's not much better for adults. This only goes up to 25, but the older you get, the more likely that treatment centers are going to say, okay, we need to treat this with pharmacotherapy. And really what they're saying in doing that is we need to treat this as a medical illness. We're hesitant to think that we need to treat it as a medical illness the younger that people are. This research, this gap in treatment, this gap in availability of pharmacotherapy for opioid use disorder in adolescents and young adults was so concerning to the American Academy of Pediatrics that in 2016 they put out a statement that strongly advocated for increasing resources for medication-assisted treatment in primary care, not just in specialty care settings, but in primary care, and of course accessing other developmentally appropriate counseling in community settings. But the real focus was on increasing access to buprenorphine and other medication-assisted treatments. They recommended that pediatricians start offering medication-assisted treatment to adolescent and young adults with severe opioid use disorders, or discuss referrals to other providers for this service. This is a really important. There's only 3 points in these recommendations. There's only 3 recommendations they made, but the recommendation that pediatricians in primary care start treating opioid use disorder is a move that's also happened within the adult population, with the awareness that if we only treat opioid use disorder in specialty treatment centers, if you have to go to rehab in order to access treatment, well, a couple of problems are raised by that. One is that when you go to, quote, rehab, whether it's inpatient or intensive outpatient, you're still very unlikely to get medication, because most of those treatment centers, when we studied treatment centers, when a national treatment study came out in 2002, just before buprenorphine was released, they said there's 3 kinds of opioid use disorder treatment. There's residential. Well, there's 4 kinds. There's residential, there's methadone, there's drug-free outpatient, they call it that in quotation marks, drug-free outpatient, and there's detoxification only, where you just get medically detoxed and then hopefully you stay off of drugs. So those 4 categories. There was no treatment in primary care. So now if you send someone to rehab, most of the time you're sending them to, quote, drug-free rehab. These are treatment programs that have traditionally defined themselves over and against methadone clinics. So they've been very slow to adopt buprenorphine treatment. When they do use buprenorphine treatment, they use it usually very briefly for detoxification and not for maintenance therapy. When buprenorphine is used in primary care settings, it's much more often used for maintenance treatment to manage the symptoms of the illness the same way you would manage hypertension and diabetes, and not with the assumption that one of our main goals is to get someone off of the medication. In the adult population, we have conclusive evidence that detoxification does not work, that short-term tapering does not work, and that medical settings that are used to managing chronic illness medically are better at implementing medication-assisted treatment than specialty settings that have to overcome these cultural and attitudinal barriers to doing it. So I think that this statement, although very simple, the pediatricians should considering offering medication-assisted treatment is really quite revolutionary for the treatment of opioid use disorder in adolescent and young adult patients. And then, of course, the American Association of Pediatrics says we need to study this more. We need to know more. I mean, if you look back at that chart I showed you before, we know so little about how to effectively treat substance use disorder in adolescence. Now, I will say one of the reasons we may have such a tough time is because if we were thinking about opioid use disorder like early onset hypertension in an adolescent where they just have, they develop a hypertensive problem early in life, it's unusual, or diabetes, they develop type 2 diabetes or type 1 diabetes even early on in youth, we would be thinking, okay, wow, we're going to have to manage this problem over the course of their lives. But because we're so focused on trying to solve the problem, every parent, every adolescent, every treatment provider wants to make the adolescent better so they can just live their life and they don't have to look back at this opioid problem they had when they were younger. And that may just be wishful thinking. Most of the evidence we have, pretty much all the evidence we have, suggests that once someone develops a serious opioid use disorder, it's something they have to manage over the long term. It's not something they just put behind them by going to inpatient treatment or by having a good intensive outpatient treatment program. Then they say, okay, I'm done with that, I move on. Or even by participating in mutual support programs. Mutual support programs have not been, even though I fully 100% support them as an adjunct to pharmacotherapy, they've not shown any effectiveness in reducing the overdose risk associated with opioids. So using primary care as a frontline treatment is both revolutionary and highly supported by the evidence. So let's look at what we see in adolescents. I'll try to do this in just about 5 minutes so that we can have some questions, 10 minutes of questions here at the end. We do have some studies, 2 good studies of adolescents, though they're small. This looks at whether using buprenorphine versus clonidine for stabilizing a patient over 4 weeks. Adolescents is more effective. Obviously, the buprenorphine retained more people. This is a really interesting chart from the same study because what it shows is in the very beginning of the study, they were, before this big line in the middle, they were requiring people to come every day for attendance. But actually, if you only require them to come 2 to 3 days a week, they were retained longer. We see a lot of analogies from this in the adult population where if we overload people with treatment requirements, they drop out of treatment. But if we treat them medically with pharmacotherapy and then engage them a little bit more voluntarily in the services they want to engage in, then they stay in treatment longer. Staying in treatment longer is associated with a reduced risk for morbidity and mortality. Pretty small study, but it's one of the only 2 that we have. And here you can say it's these same 4 groups. You have the 28. These are 2 kinds of buprenorphine detox. One is the 28-day detox. One is the 58-day detox. The longer the person is given the medication, the longer they are retained in treatment. And yet, if you have a lower burden for psychosocial treatment or lower burden for visits, then you keep people in longer. But this study is a little bit bigger and also a little bit more clear in its outcomes. They compared a 14-day detox, Suboxone as buprenorphine, with 8 weeks of maintenance followed by a 4-week taper. Now, this 14-day detox, this was like the standard of care in Missouri up until about 2 years ago, where Suboxone was used a lot, but it was not trusted so much for maintenance. It was used a lot more for detoxification. Especially in adolescents. Adolescents were lucky to even get a detox. Well, this particular sample is age 14 to 21. They were getting psychosocial treatment, so there's not a question of just providing medication alone. And they got these 2 different types of Suboxone, 14 days detox or 8 weeks of maintenance followed by a 4-week taper. At the end of 12 weeks, the 8-week maintenance followed by a 4-week taper retained more than 3 times as many participants. If you taper a person, if you're tapering people off of the medication, their cravings come back, they continue to use again, they drop out of treatment. But even more or also incredibly important is to look at the second chart. and to see that we started to lose gains in abstinence at week 8. What happened? Why did all of a sudden that second group who was on the 8-week maintenance start to use opioids again, so that by the end of the study there was no difference between the two groups in opioid use? And these are the people that are retained. So they're looking at how much the people that are retained, this is how many people are retained, this is what they're doing when they're retained, and this is how many positive opioid urine screens there are. And what happened was, this is when the tapering in that group began. So now I'm on a therapeutic dose of medication. I go to my doctor and they say, okay, well, it's 8 weeks. Time for you to start tapering off this medication. This is managing your cravings. My cravings come back and I start using again. And this is what we see in every tapering study, that the patients who are kept on a therapeutic dose of medication do better than the patients that are tapered off. And if we can just get our minds around the idea that when you treat a symptom, if you take away the treatment for the symptom will come back. That's how we treat every other illness. If we apply that to opioid use disorder, then we end up treating patients more effectively. This is the second large study we have on adolescents or youth age 12 to 24 and how they're retained in treatment over the first year. And there's about twice as many patients, young patients retained in treatment if they received medication versus if they received behavioral health services only. For this particular group, we don't have other outcomes other than retention yet, but more studies are forthcoming. However, what we can assume is that there's probably, just like in the adults, a lot more stability. I just do this to remind you, a lot more stability in the medication groups than there is in the psychosocial only group. What that stability translates into in the adult population is a 50 to 70% reduction in risk of death when people are receiving medication. And we have no reason to doubt that that does not apply to adolescents. In fact, adolescents, the difference between a 17-year-old and a 19-year-old is not that much difference. That group 21 to 24 is especially at risk for overdose death, and there's no reason we shouldn't be treating them in the same way we're treating adults with best practice. So with that, I will take a few questions.
Yep. If there are any questions, please feel free to type in the chat or Q&A or raise your hand, and we can allow you to talk.
If you start my video, they'll be able to see me, but that's all right. They can just hear me. So let's see. I can open up the chat here. All right. What is
Don't have any questions.
PY is past year. For past year substance use. Oh, you figured it out. Okay. Any other questions? If you unmute yourself, you can, I think you can ask a question.
I can unmute you if you raise your hand. Are there any questions?
I just had a comment. Thought it was very interesting. Okay. It's a lot to cover in a short time.
It is, and really great slides and research, and we'll make sure the slides are available to you.
Do insurance companies pay for maintenance drugs or medications? Yes. Most insurance companies cover buprenorphine maintenance. I focused more on buprenorphine for two reasons. Methadone is really, with an adolescent, you'd probably try buprenorphine before you went to methadone. In fact, that's required by federal regulation, if I'm not mistaken, that you've tried another form of treatment before you start methadone. But methadone can be life-saving, so I would not, the stigma surrounding it is really irrational if you're trying to save someone's life with opioid use disorder. Buprenorphine is the most effective medication in an office-based setting. And there's also Vivitrol. People love Vivitrol because it's not dependence producing, but the research is not, it's just not as effective in preventing negative outcomes. The article that I said was a good read. It's in the slides. I'd have to go back myself and look at it, but I put the reference, so you should be able to access it. Is there a one-stop shop resource for evidence-based practices in prevention? I would look at that article. That's very comprehensive. That was published in the Lancet. The Lancet is one of the most respected journals, medical journals in the country. It goes through every level of intervention, from prevention, universal prevention, targeted prevention, and it's relatively recent, 2016. I think that would be the one-stop shop, and it has a huge bibliography if you wanted to dig into one section or another.
I would also add, if you're interested in Iowa, the Iowa Department of Public Health Prevention, we can certainly provide information as well.
Says, will we email this presentation? In our first slide, you might have joined a little bit late, but it's the video of the presentation will be available at a link along with the slides. So Kara has put that.
And when I send the survey out, I'll make sure just to provide a reminder of where you can find the recording. It will take a week or two to obtain a recording, and we'll post that on the link that's in the slides.
Do you have tips for framing an opioid use screening with this age group? It depends on why you're doing it, but in general, if you're a parent, you just say, I'm just so concerned about the drug use that's going around in the school population, and this is just about me making sure that you're safe. The same way that I would. Here's the thing: if you were using drugs, you wouldn't tell me, and not because you didn't love me, not because you weren't honest, but just because that's what happens when you start using drugs. It's something that people feel ashamed about and they lie about, and I'm not going to take that risk. So I'm gonna take this the same way we would take your cholesterol or your blood pressure medication when you went up for a checkup for the doctor, or just ask your pediatrician. Say, will you just do a drug test as part of their normal checkup, because there's so much drugs going around their high school, and I think we would like to consider it as a potential medical problem. And I think the more matter of fact you do it, and I'll tell you I think the more matter of fact you are with kids, the better. What is the normal Suboxone dosage for adolescents using MAT? Great question. There's not something that's specific for adolescents. It really depends on how much they've been using and how long. The nice thing about Suboxone is that when it's used, you kind of just work your way up to a therapeutic dose, and it's not so hard to find. People start as low as 4 milligrams if the use was not as heavy, and go anywhere all the way up to 24 milligrams in the adult population, or in a heavily using adolescent population. Most patients will stabilize at 16 or 24. In someone whose use was consistent but a little bit more moderate, they might be able to stabilize at 4 or 8. I want to say something about Suboxone. I didn't actually have a lot of time to talk about the medication itself, but the nice thing about it is that it has a ceiling effect for respiratory depression. That means that if someone misused the Suboxone, took their whole bottle of Suboxone, there's a very, very minuscule risk for overdose death. You'd probably have to have like a underlying respiratory condition in order for that to cause respiratory depression. In combination with like benzodiazepines, you're at higher risk, but it's a Schedule III medication. That means the FDA considers it a less risky medication than Adderall or Ritalin that we prescribe to 10-year-olds. So because of that ceiling effect for respiratory depression by itself, it's not a risky drug for overdose. It's just really quite safe. It'll be helpful if we could see the questions. If you click on the chat little bubble, it should pop up the webinar chat. You should be able to see it.
Right. And we are at 2 o'clock, so it is the end of our webinar. So please feel free to reach out to myself, and we can touch base with Ned if there's further questions as well.
Well, thank you all so much for participating, and I hope you got something interesting and helpful.
Mm-hmm. Yes. Thank you, everyone, for participating. We'll make sure to send an email requesting participants complete a survey and a reminder of where you can find the recording and the slides. Thank you.
All right.
All right. Have a nice day.